And good afternoon, everyone, on this rainy yellow weather alert advisory in Trinidad Friday afternoon. I hope you're safe where you are. We've had a couple of reports of flooding. Everyone just make sure to stay safe, stay dry. And welcome again to Mrftt HIV STI Echo. This is our 74th episode, and today is another special invited episode where we're going to speak about an old issue that is becoming a new issue all over again, and COVID-19 and the variants of concern and what Omicron variant is doing, and how we balance lives and livelihoods versus the need to ensure that persons remain safe from what is still a very concerning virus. I think we've all gotten into a sort of complacent place because Omicron was the dominant strain and we were seeing fewer deaths and everyone's feeling okay, very good about this. But I think we need to have that optimism tempered by facts. So we again rely on the expertise of Dr. Chris Behrens, who's here from the University of Washington, who's going to speak to us about where we are heading still with COVID-19 and the new variants of concern, what that should, how that should inform both our governments, our healthcare institutions, as well as us personally in our own lives in terms of how we respond. So, Dr. Behrens, thanks again for the benefit of your time, and I turn the floor over to you.
Okay, thanks very much, Dr. Boyce. And yes, it's always good to present one of these talks. I sure wish I could be there in person, but hopefully someday I'll be back. All right, so without further ado, I want to acknowledge our sponsors and for this, who fund this kind of work. I have no relevant financial disclosures, and hopefully by the end of this talk, you'll be able to describe some recent trends in epidemiology of COVID-19, discuss the implications of this new BA.5 variant, and talk a little bit about current WHO treatment recommendations for COVID-19, among other things. So there's a new variant out there. It is called BA.5. It's an Omicron subvariant, and as this article notes, it probably should be regarded as the worst variant we have seen to date. This is sort of a phylogenetic map for those of you who are interested in this sort of thing, showing just how far, genetically speaking, this new BA.5 and its close cousin BA.4 are from the ancestral Wuhan strain, that's the WA1, and then the other sort of strains that have preceded it, Beta, Alpha, Delta, for example. It's another subvariant of Omicron, but it's got some different characteristics. It has several new novel mutations, both within and outside of the spike protein, which is the part of the virus that binds to epithelial cells and where we typically see the most mutations, because this is how it is better able to latch onto cells and infect others. We continue to climb the ladder of COVID infectivity with this latest BA.5 strain. This is kind of a snapshot of sorts, an illustration of just how much infectious each variant has been over the prior variant. And we saw a big jump with the original Omicron variant over the Delta. It was about a threefold increased infectivity. Then BA.2 added another 30%, this BA.5, another 10% increase in direct infectivity. But there's even more to the story. It looks like this BA.5 has developed ways to basically suppress the immune system in ways that make it better able to infect cells. It expresses these innate immune antagonist proteins that probably contribute to its ability to infect airway cells. And the consequences of these mutations and its ability to suppress the immune system are that this new BA.5 variant is much better at evading the immune system. It's better at evading the immune system in people who have been vaccinated. So it reduces the effectiveness of vaccination. Panel B on the left shows the neutralizing antibody responses in people before and after a booster vaccine with a messenger RNA-based vaccination. The BA.5 is shown in green, and as you can see, after the booster, the neutralizing antibody response that protects against BA.4 or BA.5 is reduced as compared to prior strains. On the right side panel, number C, we find that prior infection with a Omicron subvariant BA.1 or BA.2 does not provide as much protection against BA.4 or 5 as prior infection does against other variants. So basically the mutations that this new virus, this new subvariant has, reduce the impact of vaccination and of prior infection in terms of providing protection against BA.5. And we know from data that were just published a couple days ago, posted online from Cotter, that protection against previous strains of the protection afforded against BA.5 by prior infection with an Omicron variant such as BA.1 or BA.2, we know that's reduced. But it's even much more reduced if the prior infection was a non-Omicron variant, right? And so this is kind of a busy table. I didn't have time to really clean it up, but in each sort of highlighted row, you see the difference in terms of the effectiveness or the level of protection of prior infection against BA.5 based on whether that prior infection was with a BA.1 or BA.2 Omicron subvariant or a non-Omicron variant. And there's a pretty dramatic difference in the sense that if you've been infected in the past with a non-Omicron variant, you get very little, if any, protection against BA.5, right? It's just doesn't seem to even appear to be very relevant. So I'm trying to sort of summarize here what we've learned so far about BA.4 and 5. Again, 4 and 5 are very close cousins. And so often we're seeing both of them and often they're kind of lumped together, although really it's BA.5 that we're seeing more of. BA.5 is more infectious than its immediate predecessor, BA.2. It has this ability to suppress the immune system and evade the immune system, resulting in less protection from vaccinations, from prior infections, especially if they were non-Omicron infections, and from monoclonal antibody treatments. We don't know for sure whether or not this strain is inherently more pathogenic or more virulent. There's some suggestion from a hamster model that in fact it may be more effective at infecting cells in the lung, for example. But those are rather preliminary data, so I wouldn't necessarily hang my hat on that. But all of this is translating into new infection waves globally. So just to shift to the epidemiology a little bit, we're seeing increasing rates of COVID infections and hospitalizations as shown in this graph, really all over the world. In both hemispheres, this is mostly, showing what happened in South Africa, where the BA.4 and 5 variants seem to have started, and what is now going on in other parts of Europe and the United States, again, in terms of hospitalization rates. We are seeing particularly high hospitalization rates in Oceania, like Australia, for example, and in New Zealand, along with a big increase in new cases. New Zealand had really managed to escape the epidemic to date, but they're not escaping BA5. And they're seeing a real unfortunate spike, not only in cases, but also in deaths from COVID-19 now. Here in the United States, the BA5 variant is now the majority of new infections, and it really replaced the prior Omicron strains very quickly, a very steep curve there. And I think we can expect to see that happen wherever it lands, because wherever it has landed to date, BA5 has very rapidly displaced whatever variant had already been in the circulation. With that, we are seeing an uptick in cases. It's the reported cases is not nearly as high as we saw during the initial Omicron wave during the winter. However, there is reason to believe that this case estimate is is really significant undercount. So, for example, if you overlay the cases reported in, say, San Francisco with a graph of COVID-19 detected in wastewater, well, you see a very different story. You see levels of COVID-19 in the community that essentially match what they were during that Omicron surge in January. And part of what's probably going on here is, frankly, a lot of people are no longer getting tested, either getting tested at all, or they're, whatever testing they're doing is using these home testing kits, which of course are not captured in national databases. So there's reason to believe that case counts that we're starting to see, at least here in the United States, are probably a significant underestimation of what's really going on. Furthermore, the test positivity rate has gotten very high, and usually a high test positivity rate means that we're not testing enough, and it means that there are probably a lot more cases out there than we are detecting. Now, again, these are cases reported and captured by public health because they're from testing done, either at public health labs or at pharmacies that record this information. So again, it supports the theory that we're actually have a lot more cases out there than the official data suggests, probably because people are relying on home testing or not getting tested at all. The test positivity rate is even higher based on this source of data from Walgreens, a national pharmaceutical chain that offers free COVID testing. Positivity rate exceeding 40%, which matches what it was at the peak of the Omicron epidemic in January. So again, based on the wastewater data, it's possible we're actually seeing case rates as high as they were during the initial Omicron wave during the winter. Hospital admissions are climbing as well. These are data from across the United States. I can speak from my own experience at my hospital where I work. Yes, cases are definitely going up. And we're seeing an increase not just in hospitalizations, but in patients with severe illness, those in the intensive care unit, for example. And that is placing additional burden on an already stressed healthcare system here. Every single hospital in my region is at over 100% capacity, and we're having to make sort of emergency changes to how we handle inpatient flow just to accommodate this problem. We are seeing an increase in mortality as well. This is from Los Angeles County. Los Angeles County has over 10 million people, and they are seeing a significant increase in mortality due to COVID-19 as well. So very real impact in the United States from the BA.5 variant by whatever metric you use, including the most clinically relevant hospitalizations, ICU, and mortality. Looking sort of more relevant locally in Trinidad, these are the latest data. Cases are not high. Maybe they're going up, maybe not. Barbados, on the other hand, for example, is going up, very nearby country. My hunch is that Trinidad will follow Barbados, and that Barbados may perhaps have just been the first island country in the region to see this spike. And I hope I'm wrong about this, but given what we've seen elsewhere, and given what Dr. Boyce said earlier, that they have picked up BA.5 in Trinidad, my concern is that we're going to see a similar rise in cases right there in Trinidad and Tobago. Now, I'm going to shift a little bit and talk about the high cost of COVID reinfection. This new BA.5 is being referred to as the reinfection wave because, as I mentioned earlier, prior infection doesn't give a whole lot of protection against it, especially if that prior infection was non-Omicron. But there's a real downside, it turns out, to getting recurrent infections with COVID. These data I'm about to review were posted online recently by researchers at the U.S. Department of Veteran Affairs. They looked at a very large database of VA patients, comparing outcomes among those who had just one infection versus those who had 2 or more infections. And they used a non-infected control group as well to compare these outcomes. And they estimated risks and 6-month burdens of all-cause mortality, hospitalization, and set of pre-specified incident outcomes. This is, part of what they found. Basically, persons who had a reinfection with COVID were more likely to experience all of these various poor outcomes with the hazard ratio shown below. And at the top, basically what this is saying is that getting a second infection with COVID doubles your risk of mortality as compared with having had just one infection. And that kind of increase in the hazard ratio, anywhere between 1.5 to 3, we see across the board with various other markers of pathology, whether it's hospitalization or different organ groups. Moreover, it seems to be cumulative with additional infections. So they were able to even break it down according to people who had had 1, 2, or 3 or more COVID infections. And with each successive infection, the risk of these bad outcomes steadily increased. So reinfections are not pretty, and it's not necessarily the same degree of risk as it was the first time around. Every reinfection seems to significantly increase the risk of developing severe complications. Unfortunately, vaccination didn't seem to make that big a difference. But I want to be very clear what I'm saying here. Vaccination definitely reduces the risk of getting COVID in the first place. But if, according to these data, you get COVID reinfection despite vaccination, that risk of having a worse outcome, a significant complication, is still increased with a second or more infection as compared to just one, right? So I hope that makes sense. So what do we do about this BA.5? I hope I've made the case that this is a subvariant to be taken very seriously, and that, you know, the editorial I mentioned suggesting this is the worst variant we've seen yet, that this is, you know, probably an accurate assessment. Well, the fact is we know what works. It's multiple interventions, none of which are perfect, but when combined, add up to a very significant level of both public and personal protection. It's kind of been illustrated well, I think, by what we call the Swiss cheese respiratory virus pandemic defense. You know, in this model or analogy, every intervention is like a slice of Swiss cheese. You know, and Swiss cheese slices have holes in them, but if you stack enough up, you essentially seal off all the holes. And that's what we need to do with our interventions. And we know that the interventions that really are the most effective are the vaccinations, masking and ventilation, social distancing, and more recently, we have treatments that are also very effective. So let me talk a little bit about vaccinations and especially the importance of boosting. We're starting to see some data come out that shows us exactly how important it is to get booster vaccinations. To get booster vaccinations in order to prevent severe outcomes from COVID infection. These are data from Israel, and they looked at the composite outcome of death or mechanical ventilation within people who had serious COVID illness, so had to be hospitalized. And they broke it down according to whether they had had 3 versus 4 doses of the Pfizer-based messenger RNA vaccination, and getting a 4th dose, a second booster shot, significantly reduced the risk of death or needing to be ventilated as compared to having had just 3 doses of that Pfizer vaccination. We have similar data from the United States, looking at individuals over 50 years of age. This is comparing rates of COVID-19 deaths according to how many vaccines had been received. The black line is individuals who had no vaccination whatsoever. The blue dotted line, those who received the primary series only, so those 2 initial shots. The dark purple is those who received 1 booster dose, and the light purple, those who had received 2 booster doses. And what we see is that having had 2 booster doses provided like 99% protection against COVID, against mortality, against dying from COVID. And so I mean, the first point is getting any vaccination provides an enormous boost. And then the second point is that 4th dose, if you can get a second booster vaccination, makes a very significant difference as well. And so to sort of, you know, calculate the numbers in a different way, among those ages 50 years and older, unvaccinated people had 42 times the risk of dying from COVID-19 compared with people who had gotten the vaccination series plus 2 booster doses. And among those who had a primary series and just 1 booster dose, had 4-fold the risk of dying from COVID-19 as compared to those who had had 2 or more booster doses. So if you have access to the messenger RNA vaccines, get every booster shot you can. It makes a real difference. We have similar data from Sweden, looking interestingly at all-cause mortality, right? Not just COVID-19 mortality, but all-cause mortality in long-term care facility residents. Again, we see a similar pattern, a 4th dose, a second booster of the messenger RNA-based vaccination provides significant additional protection as compared to having received just the initial series plus 1 booster or 3 doses. And that benefit extended to the very elderly, to individuals 80 years of age or older. So it extends across extreme age ranges. Okay, briefly, the importance of masking. Masking is extremely effective. It does make a difference what mask you wear. The N95 masks are clearly the best. These masks protect not only the individual who's wearing them from getting COVID, but they also protect others around an individual from contracting COVID if the person wearing the mask actually has COVID infection. So the masks work, in both ways. They protect yourself and they protect those around you. And if they're N95 masks, they're extremely effective. Fortunately, I mean, there's been a lot of, I think there's been some advances in making these N95s or KN95 masks a lot more comfortable and wearable. So you don't necessarily have to have these very uncomfortable, really tight fitting respirators. These kinds of commercially available KN95 masks, honestly, I've worn several different models. A lot of them are reasonably comfortable. And they provide, as I mentioned, a lot of protection, essentially due to the fact that they combine multiple layers that work in different ways to filter out aerosols and the aerosols that contain the virus. Now, let's talk a little bit about treatments, because there are treatments for people who are not severely ill that can make really a significant difference. The WHO has published this living guideline regarding therapeutics for COVID-19. I think it's very well written and worth looking at. They update it continuously, which is why they call it a living guideline. And that's the URL right there for how to access it. But they have a very nicely laid out flow chart for what kinds of patients should consider what kinds of treatments. And 2 of the treatments that are highlighted in this document are 1, nirmatrelvir plus ritonavir, also known as Paxlovid, and then molnupiravir is an alternative. I reviewed this in a prior lecture, but very interestingly, the way these medications work is very, very similar to the way our HIV medications work. Essentially, they are protease inhibitors, replication inhibitors that disrupt the viral life cycle, just like many of our medications do that we use to treat HIV. And we know from very good, high-quality randomized clinical trials data that the nirmatrelvir ritonavir reduces the risk of hospitalization by about 88% among patients who have confirmed COVID, but are not sick enough to require hospitalization. So these are outpatients. As long as they start it within 5 days, there's a very high level of protection from progression to severe illness that requires them to be hospitalized. Molnupiravir, the other sort of oral treatment that's popular out there, also effective in that regard, though not as much as the nirmatrelvir ritonavir. And one thing the guidelines have, as I'm highlighting here, is this interactive tool called Match It. And it's worth taking a look at. This is the URL for it at the bottom, but it is interactive, and I think it very helpfully highlights just how effective these different treatments are and what impact you can expect to see them have. So, for example, if you have 1,000 patients with if you have 1,000 patients with this illness and you treat them, you can expect 84 fewer to end up in the hospital. Similarly, 43 fewer for molnupiravir, not quite as effective, but it puts this all out graphically in a way that I think is very helpful for us as clinicians to understand, and also for conveying that message to patients. Now, however, none of this information is very helpful if the drugs are not available. And there's concern that we're repeating a lot of the mistakes we made with the HIV pandemic in terms of not allowing better access to these potentially life-saving treatments. The licensing status of these two medications is unfortunately poor throughout the lesser income countries. In the Caribbean region, as far as I can tell, the nirmatrelvir is not licensed in any of the countries. Perhaps we can talk about that a little bit. I don't know if anybody has any additional information, but that's really a shame, because these medications really do make a difference, and it's worth trying to get them. Encouragingly, the Dominican Republic has filed a brief with the WTO, the World Trade Organization, for what's called compulsory licensing. This was a strategy that was used to essentially force pharmaceutical companies to give up their patents and share the technology so that generic versions of these medications could be more widely distributed. I haven't been able to find a clear update on what's happened to date with that application. So last but not least, let's talk a little bit about the future of COVID. Where might we be headed? First of all, we need, of course, to be vaccinating more. Globally, the vaccination rates really continue to lag. And by the way, according to this metric, when we say fully vaccinated, it means completing the primary series. It does not mean completing the primary plus booster shots. And as I showed, those booster shots add a lot more protection. But even restricting our analysis to, completing the primary series, we're looking at less than 2/3 of people in the world have managed to do this. There's a very wide variation across different countries as to how well they've accomplished this. Somehow, United Arab Emirates has managed to do this for 107% of its population. So I don't know how that's possible exactly. Obviously, some kind of data error there. But as you can see across various other countries, it really varies. I don't know. And just looking at the Caribbean region, these are some of the vaccination rates that I was able to identify across Barbados, Trinidad, Bahamas, and Jamaica. In Trinidad and Tobago, only 47% have fully completed the initial series, so like the first 2 shots or 1 shot if we're talking about the Johnson vaccination. And then, if we look at partially vaccinated, we're up to 49%. Again, not at all including those who, this does not account for those who have not received booster shots. Unfortunately, we know that immunity fades away from prior infection, which is sort of what I showed, with especially relevant with the BA.5 variant. So we cannot count on herd immunity to carry us through. There's the problem of inherently fading immunity, and then there's the problem of new variants that are better able to evade whatever immunity was derived from a prior variant. So basically, we really need to up our game with vaccination if we're going to get out of this. We need more testing. There's a severe deficit of testing in low-income countries. Without the testing, it's very hard to know exactly what's going on, very hard to target public health resources, et cetera. So I think, honestly, if we look at the way things are evolving, we're going to continue to see new variants. We're not containing the infection very well. We're not getting people vaccinated adequately. We have a lot of people who are immunocompromised out there who are getting COVID. These are individuals in whom new variants are most likely to evolve because the virus can stick around longer within that individual and gives it many more opportunities to mutate into new variants. And then, of course, there's always a risk of new variants coming from animal reservoirs or co-infection and recombinant strains, similar to what we've seen with HIV. And because we keep climbing the ladder of infectivity, it's likely that future variants will be more infectious. That's how they displace the currently circulating variants, and it's been the story to date. There is a even newer variant out there called BA2.75, also known as Centaurus. This is a sort of a different lineage. It's not an evolution from BA4-5. It's an evolution from BA2, but in a slightly different direction, with some mutations that are shared with BA4-5 and some that are new. Really, it's taking off in India right now. The other countries shown, the numbers are so tiny, it's sort of not sure what to make of those. So I would ignore the blue and the red dotted lines here. It's really that sort of greenish color in India that's a little concerning. We don't really know what's going to happen with this new variant. Interestingly, there was very little BA5 in India, so we haven't seen BA2.75 go head-to-head against BA5. So we don't really know whether it will be, a variant that will displace it or not. But it's something to keep an eye on. And in case you're wondering how I got that name, some random guy on Twitter just decided he was going to call this new variant Centaurus, and he announced it. And somehow that took off. I think people are tired of calling all these Omicron subvariants by numbers that look like IP addresses, and instead gave it a whole different name. So there we are. The newest one is Centaurus, but we don't know if it's going to be a significant problem or not. But what we do need to do is develop new and better vaccines. Moderna is trying to develop a Omicron-specific vaccine, but how effective will it be against, for example, BA.5? Or by the time it comes out, will we have moved on from Omicron entirely? In other words, it can be very hard for the vaccines to keep up with these new variants. So what we really need are vaccines that are sort of specific across all variants, or variant-proof vaccines, so to speak. Ones that would target areas that are highly conserved within the SARS-CoV-2 virus, and therefore makes it very hard for the virus to sort of mutate in a way that makes it less susceptible. And it would sure help if we could get a nasal vaccine. Many people are vaccine hesitant because they just don't like getting injections. A nasal vaccine might help to get around that. And furthermore, a nasal vaccine would likely be better at inducing mucosal immunity. So better able to perhaps allow or train the immune system to block the virus before it can even get a foothold in the nasal or oral mucosa. So, excuse me, I'm gonna stop there and open it up to questions and discussion.
Thank you, Dr. Behrens, for, as usual, a wonderful, if not slightly worrying presentation. I'll just open it for if anyone to see. Conrad, you have your hand up.
Yes. Hi, Chris. If we do in fact work towards getting vaccines that are kind of more generic in fighting all different types of variants, wouldn't we also stand the risk of creating vaccines that could also become, what's the word, weaker in some sense as well? Because if it's attempting to fight everything and something should go wrong, wouldn't it then mean that it would be ineffective for everything?
Yeah, interesting take. Well, I mean, such a vaccine would have to be, of course, extensively tested first. And so, you know, there would have to be all the phase 1, 2, 3 clinical trials to establish that it's truly effective and truly safe, right? So I think we could at least ensure in that manner that the vaccine isn't too weak. I think there's, however, you know, it's reasonable to ask, well, how can we be sure it will truly be, you know, effective against any and all potential subvariants or variants of SARS-CoV-2? Maybe they're, you know, the viruses just tend to evolve in ways that we don't anticipate, and doesn't it seem like there could be the possibility that it, despite our best efforts, it figures out a way to evolve its way to develop immunity even to that kind of vaccine, and then maybe we're in more trouble. Yeah, I'm not really sure. But it might be a risk worth taking, given how how awful things, you know, continue to be with COVID, right?
Chris, quick question for me. Has there been any change or change the wrong word, I think refinement in terms of who the persons at highest risk are? Is it the same population that we assume would be at the highest risk from the beginning? You know, immunocompromised, chronic respiratory disease, chronic kidney disease. Has there been any, as the data is coming out, any addition to that group, or any changes in terms of perceived?
Sure. Yeah. I have not seen any real modification to our initial impressions of who is at highest risk from this. I think what we are seeing is, with respect to long COVID, it seems like just about anybody is at risk for that, not just those with those original list of risk factors. So in other words, the risk factors for getting infected and having severe outcomes, I think that, you know, list of criteria remain essentially unchanged. I've seen nothing to suggest otherwise. But as we learn more about, you know, so-called long COVID, people who seem to have persistent symptoms and other problems several months out, the data I have seen suggests that, you know, risk factors don't seem to apply that much there. It seems that, you know, even if you know, anybody can get long COVID, and long COVID doesn't seem to focus, or you know, the risk doesn't seem to be that increased among people with risk factors, or people who had more severe disease. We're seeing a lot of long COVID among people who had mild disease first, you know, when they had it. So that's my take on this situation.
Okay, thanks. Okay. And remember, anyone, if you can't speak where you are, you can always type a question in the chat box.
I'm curious about the, you know, Paxlovid situation there. I feel I cringe a little bit inwardly to present this information about how helpful the meds are, but it seems insensitive to do so if you just don't have any access to it. But I'm trying to make the case that it's worth trying to get those meds. Where do things stand with that? Do you have any insight? I had a hard time finding that out.
Not personally, but I see Dr. Edwards and Dr. Seaver are attending. Do either of you have any insight from the ministry side in terms of how we might be getting access, if any at all?
I don't know, considering the amount of deaths, 2 to 3 a day, I'm not sure that they actively pursuing it, but I think we're going to get a new wave soon because, they're going to remove the mask mandates. And I recently traveled and nobody's wearing masks. Nobody's wearing masks on the planes, so the next wave is going to come soon. So according to Chris, I agree with you, we may probably need some of those drugs, but right now it's just 1 to 2 deaths. So I don't think, anybody sees urgency in it yet,
Mm-hmm. Got it. And how about the vaccination situation? I pulled up the data I was able to find, suggesting that,
probably about 50, just over 50%.
Okay, just over 50% for completing at least the initial series.
Yep. And
what about? Oh, go ahead. Sorry.
No. They're not rushing to take any more vaccines. Most people telling me, okay, I had my 2 doses. That's it. I'm good. The people who travel and stuff will go and take the boosters and stuff, but most people are not.
What about? Is there public health or other messaging sort of urging people to get the boosters, or what's your read on that? And what is the supply adequacy? Is there enough to reasonably be trying to vaccinate to give boosters?
We had a good supply of Pfizer vaccines, and they expired because people weren't taking them on. They weren't taking them, so some expired. I think probably 30,000 or so expired because they just weren't taking it. The messaging is out there, but as I say, I think people are wary now of COVID, and they had enough. But a new wave is going to come and hit us soon. So I mean, we can't let our guard down.
Mm-hmm. We've been letting our guard down here in the United States for years, so no judgment there.
I wonder if I can ask a question about long COVID, because I seem to remember that during one of our previous conversations you mentioned there. I don't know if it was at your center or a different center. They were actually opening. They had opened almost like a post-COVID clinic for persons who might have long COVID. And do we have a reasonable definition of what long COVID is? What is the case, and how do we surveil for it among our patients who have been diagnosed with COVID? Because there was one of our patients who has abdominal pains, collapsing at work. I'm getting a letter from a job about if she's still fit, and I'm wondering, what is this long COVID? Is this something else? How do we approach that as caregivers?
Yeah, good question. There is a long COVID clinic at the hospital where I work. I have not actually, been to it or talked to the people who staff it, so I'm not sure exactly what they do or exactly what criteria they use. This is whenever a sort of new illness is in its infancy, there's this period of sort of initial confusion and controversy about what are the criteria for, the case definition criteria, et cetera. But, what I've seen more than anything, I think, is at least 6 months, 6 months out, persistent symptoms that were, absent prior to the COVID infection, and that seem to have their timing, right with COVID. Honestly, I'm not aware, of any clearly effective treatments either at this time. I remember seeing some reports of, these anecdotal reports of if people hadn't been fully vaccinated, getting the vaccine seemed to often improve symptoms. I've seen some anecdotal reports of IVIG, intravenous immunoglobulin treatment, maybe helping these individuals. I've seen some reports that, well, often in many people, it does very gradually get better. So I'm not really, I don't think we know how to treat this yet. I think if somebody has what seems like long COVID and they have not been fully vaccinated, it's worth vaccinating them, because honestly, it's worth vaccinating them regardless. And maybe you'll see some benefit from that. But outside of that, I'm not aware of any treatments. So I'm not sure exactly what they do in this clinic for long COVID. It's something I've been meaning to find out. Yeah, active surveillance, I think, I don't know about active surveillance, but if you have patients who have these odd symptoms that clearly started with COVID and are lingering, very well could be.
Okay. All right. Thank you so much.
It's very much an active area of research, because there's many of the features seem to overlap quite a bit with what we call chronic fatigue syndrome. It's gone by various names, myalgic encephalitis, systemic exertion intolerance disorder. So there's probably some underlying pathophysiology driving perhaps these different disorders that, if I had to guess, I would suspect it's the immune system is out of whack as a consequence of the infection. Either it's overstimulated or underactive, or a combination of two, depending on what parts of the immune system we're looking at. So my hunch is that some kind of immune modulation therapy will be ultimately what might do the trick for these individuals, but that's really just speculation.
That's it. So, any other questions for Dr. Behrens before we close up on this? Again, not as rainy as when we started Friday. Sunlight through the clouds, so I'm going to have to swim home today.
I have one other unrelated question. Are you seeing any monkeypox in Trinidad yet?
Thankfully not. There was one young man, actually, we saw yesterday, no, day before yesterday and today, who had these vesicular sort of lesions, but when I kind of dug into the history, they started in April. And it's been recurrent, and he had it in his mouth, and it cleared up with the Valtrex. And
Okay.
I actually think he might be having HSV iris because he had a period of default of loss of follow-up, and we started in April, and right after we started, he got this rash of HSV lesions, but they were appearing in funny places, which is why I think it might be more of that than anything else. So we got a bit of a scare.
Okay.
I was discussing the case with Dr. Edwards, but he has no travel history since the year began. He has no outside contact since the year began. So it's unlikely to be monkeypox. But there has been a case in Jamaica that escaped the hospital.
I know. I saw that. The reason he escaped, he wanted to enjoy his vacation.
Yes, of course. Yes. Why wouldn't you?
Why not? But they got him back. Okay, well, I'm glad to hear that you're not, and hopefully, knock on wood, you won't be seeing it.
All right. Okay, so I think we can wrap up this a little bit early today. So just a quick housekeeping announcement. Our next echo session is on the 20th of July. That's in 2 weeks today, but on a back to regular Thursdays. It will be an HIV topic, yet to be determined. And again, we just thank all the persons who stayed back, despite the weather and the thunder and small earthquake yesterday, to spend some time and learn something from Dr. Behrens. And Dr. Behrens, again, thank you for supporting us at our echo sessions in Trinidad. I hope all stays well with you in Washington and the University of Washington and ITech. And again, we thank you for all the time and the expertise and the knowledge that you share with us. So I think we will sign off today. This is Mrftt HIV STI Echo. And have a good weekend, everybody. Take care.
Okay. Thanks, everyone.
Okay, bye-bye. Thanks a lot.